Okay, we'll talk for a while about inflammatory bowel diseases. We're going to compare and contrast Crohn's disease with ulcerative colitis, also known as UC, so that you can identify which one of the diseases your questions are asking about. Both Crohn's and UC are potential causes of a lower GI bleed. In both cases, the etiology is incompletely understood. Crohn's is thought to be related to a disordered response to intestinal bacteria, whereas UC is thought to be an autoimmune disease. Which parts of the GI tract do Crohn's and UC affect? If you remember nothing else about these two, please remember that Crohn's disease can involve absolutely any portion of the GI tract, from the lips down to the large intestine. Ulcerative colitis, on the other hand, is strictly limited to the colon. It is UC colitis because it affects the colon. This is an absolutely critical thing to remember. That being said, the terminal ileum and colon are the most commonly affected regions in Crohn's disease, so you cannot diagnose one or the other solely based on location. Crohn's disease also has skip lesions, meaning that you can have an affected area, then a normal area, and then another affected area. The rectal area is spared, whereas in UC, the rectal area is always involved. Okay, on to the pathological features. How can we distinguish between Crohn's and UC? In Crohn's disease, you have transmural inflammation, meaning all layers are involved. In UC, on the other hand, only the mucosa and the submucosa are involved. This means that in Crohn's, you can have perforations and fistulas that would never occur in UC. Crohn's also has the features of cobblestone mucosa, creeping fat, bowel wall thickening, such as the string sign, which you can see here, and fissures and fistulas. You also can see linear ulcers, which are shown here in this colored image. In ulcerative colitis, you can find pseudopolyps, which are seen here, and they have freely hanging mesentery. The inflammation causes a loss of haustra, which eventually gives the lead pipe appearance on imaging. Microscopically, these are also quite different. Crohn's has non-caseating granulomas and lymphoid aggregates. Remember, Crohn's has non-caseating granulomas. This is really important to remember. UC, on the other hand, does not have granulomas, but instead shows crypt abscesses and ulcers, as well as bleeding. The clinical features are also quite different between Crohn's and UC. In Crohn's, the major source of morbidity and mortality are strictures, fistulas, perianal disease, malabsorption, and nutritional depletion. Colorectal cancer also occurs at a higher rate than in the normal population, but cancer is an extremely high risk in UC. UC similarly has malnutrition, and a devastating complication is toxic megacolon. Both certainly have diarrhea, and in Crohn's it may or may not be bloody, but in UC it is always bloody. There are also important extraintestinal manifestations to remember. Patients with Crohn's may have migratory polyarthritis, erythema nodosum, ankylosing spondylitis, uveitis, or other immunologic disorders. Patients with UC, on the other hand, can have pyoderma gangrenosum, or primary sclerosing cholangitis, as well as ankylosing spondylitis or uveitis. Treatment for Crohn's consists of corticosteroids and infliximab. UC treatment options include sulfasalazine, 6-MP, and infliximab. Prophylactic colectomy is usually performed due to the extremely high risk of cancer. A mnemonic that might help you remember and organize your thinking about Crohn's disease is a fat granny and an old crone skipping down a cobblestone road away from the wreck. This helps you remember that there's fat wrapping around the intestines, as well as granulomas in Crohn's disease, and they can have skipping lesions, give a cobblestone appearance, and are rectal sparing. Okay, that was a lot of information, so let's do a flash quiz to solidify all that we've just gone over. On colonoscopy, a patient with inflammatory bowel disease is found to have friable intestinal mucosa that abruptly stops in the mid-transverse colon. There is no break in the involved portion. What is the likely diagnosis? That's right, it's ulcerative colitis. Remember, UC is usually continuous from the rectum, with the rectum almost universally being involved. Alright, let's try to keep all this terminology straight. We just talked about Crohn's and UC, which are inflammatory bowel diseases, or IBD. Now we will talk about irritable bowel syndrome, or IBS. The primary symptom of IBS is recurrent abdominal pain, and other features include improvement of pain with defecation, change in stool frequency, and change in appearance of stool. It is most common in middle-aged women, and the symptoms are usually chronic. Patients may have diarrhea or constipation or both, and there are no structural abnormalities. Pathophysiology is multifaceted, which in some cases mean there's a large psychiatric component. The goal here is symptom control. You can often think of this disease in cases where there are no red flag symptoms, such as rectal bleeding, tenesmus, weight loss, greasy stools, etc., and the patient has alternating constipation and diarrhea. Okay, let's now move on to appendicitis. You're probably familiar with appendicitis, so we'll go through this more quickly. All age groups can be affected, including pregnant women and even medical students. It is the most common reason for emergent abdominal surgery in children. In kids, it is often caused by lymphoid hyperplasia after a viral infection. And in adults, it's usually due to obstruction from a fecalith, which you can see here. How does it usually present? The classic story is periumbilical pain that changes to localized pain at McBurney's point, which is seen here. Nausea and fever are common, and if it perforates before surgery, patients will develop peritonitis. You may see psoasis, obturator, and Rovsing signs. Remembering back, psoas sign shows irritation to the iliopsoas of the hip flexors in the abdomen. A positive psoas test is when extending the thigh of a patient lying on their side with their knee extended causes them pain. Thus, inflammation of the appendix can cause a positive psoas test on the right side. Inflammation from the appendix can also cause the appendix to become inflamed and enlarged, and hence cause a positive obturator sign. Finally, Rovsing sign is where if you press down on the left lower quadrant of the abdomen, the pain on the right side increases. This can also indicate appendicitis. Your differential at the very least should include diverticulitis, which is more common in the elderly, and ectopic pregnancy, which of course is only worth checking in females. Remember though, that if you're suspecting appendicitis in a young female, you should at least check a beta HCG to rule out a possible ectopic pregnancy. Treatment of appendicitis is critical to treat by appendectomy. Now we'll talk about the spectrum of diverticular disease, from what exactly a diverticulum is to diverticulosis and diverticulitis. The definition of diverticulum is a blind pouch protruding from the alimentary tract that communicates with the lumen of the gut. In other words, there's a pouch formed as if you pressed a finger from the inside of the gut outwards. You can see an image of diverticuli here. Most of the diverticula are acquired, and most commonly they're in the sigmoid colon. Another important definition is that of true versus false. True diverticuli include all three gut wall layers, whereas false diverticuli or Pulsion diverticuli include only the mucosa and the submucosa. This is important to remember. Often, these false diverticuli occur in places where the muscularis externa is thinned by the perforation of the vasa recta. What, then, is diverticulosis? Diverticulosis is a condition where the patient has many false diverticuli. It is quite common, and it's due to an increase in intraluminal pressure along with focal weaknesses in the colonic wall. Patients generally have a low-fiber diet and occurs mostly in the sigmoid colon because at that point the stool is hardest after most water has been reabsorbed. This condition is usually asymptomatic, but is the most common cause of hematochezia. Often, a patient with a single episode of a lower GI bleed that spontaneously remits has bleeding from diverticulosis. You can see a picture of a diverticula here. Diverticulitis is a complication of diverticulosis and occurs when there is inflammation of one or more of the diverticuli. Classically, an older patient presents with lower left quadrant pain, fever, and leukocytosis. Another rare complication of diverticulosis is colovesical fistula formation, or a fistula with the bladder, which can lead to pneumaturia or the sensation of peeing out air. Antibiotics are the initial therapy. Let's now talk about Zenker diverticulum. Zenker diverticulum shares certain outpouching features with diverticula found in the colon, but it actually occurs in the esophagus, where the pharynx transitions to become the esophagus. This is called the Killian triangle. Zenker diverticulum is a false diverticulum, which, as you remember, means what histologically? That's right, it contains outpouching of only the mucosa and the submucosa. This commonly presents on the boards as halitosis from trapped food, but the major complaints are from dysphagia and obstruction. Here you can see a barium swallow where an outpouching, which you can see here, is the Zenker diverticulum. Whereas Zenker is a false diverticulum, Meckel's is actually a true diverticulum, meaning it involves all three layers. It involves the mucosa, submucosa, and muscularis externa. Meckel has the classic rule of twos. The pouch is 2 inches long, occurs 2 feet proximal to the ileocecal valve, is found in 2% of the population, presents in the first 2 years of life, and it may have one of 2 types of epithelia, either gastric or pancreatic. It is related to persistence of the vitelline duct or yolk sac. If it does contain heterotropic gastric or pancreatic tissue, this tissue can be active and produce its normal products. This is the most common congenital anomaly. It can be asymptomatic, but it can also cause bleeding, intussusception, volvulus, or obstruction. It can be diagnosed with a protectinate study, or more commonly referred to as a Meckel scan. Based on what you know about embryology, can you deduce what the protectinate detects? That's right, it detects the presence of gastric mucosa, which is present in Meckel's diverticulum, since it occurs as a failure of obliteration of the omphalomesenteric duct. A note from embryology is that while Meckel's is persistence of the vitelline duct, a different condition is omphalomesenteric cyst, where the vitelline duct is abnormally dilated. Next, let's talk about intussusception and volvulus. Intussusception is when there is telescoping of a bowel segment into a distal bowel segment, which can compromise blood supply. You can see this here. This is more common in children with a potential viral etiology. And if it occurs in adults, it is generally from an intraluminal mass or tumor. This is a surgical emergency in kids. On the boards, this presents as the classic description of currant jelly or bright red stool. This is a really important association to make. Whereas intussusception is telescoping, Volvulus is a twisting of a portion of bowel around its mesentery, usually at the cecum or sigmoid colon. Volvulus can cause obstruction or infarction and is most common in the elderly. Let's next talk about Hirschsprung's disease. Hirschsprung's is a congenital disorder caused by failure of neural crest cell migration to the distal colon. Megacolon develops because of the lack of ganglion cells that prevent the colon from relaxing to allow stool to pass. These are the Auerbach and Meissner plexuses. Babies have constipation and usually cannot pass meconium. Imaging shows a transition zone with dilated bowel proximal to the aganglionic segment and is diagnosed by performing a rectal biopsy and seeing an absence of ganglion cells. Note the dilated air-filled loops of the right colon, which you can see here. Surgical correction by removing the aganglionic section is the standard treatment. A related point is that risk for Hirschsprung is associated with the RET gene and is increased in patients with Down syndrome.